This is ASAP Pathway. Hey friends, welcome to another episode of ASAP Pathway, the podcast. I'm your host, Dr. Stacy, and I'm excited. We're taking a journey to another part of the world today with my new friend, Dr. Rafif Tayara. Did I say that correctly, Tayara?
Yes, thank you.
It's a pleasure. We were just saying before I hit record, like it's been like 8 months. We scheduled this a while ago, I think.
Yes, it's been ages.
Ages. So I'm very excited. I see what you're doing on Instagram and on social media, and I'm so impressed with what your mission is, which is in total alignment of what we're doing with ASAP Pathway. And so many people around the world are doing this. And sometimes you feel like a little island, right? Where you're like going on this uphill battle and you feel kind of alone. So I just wanted to bring you on today and reassure you you're not alone. You have a lot of people across the world doing what you're doing. And if we could all, support each other, that's what we're here for. And I want the world to hear your story. I want other dentists, pediatric dentists, orthodontists, periodontists to hear your story. And I think it's going to encourage a lot of people. And again, it's going to raise awareness to the listener that isn't in healthcare, but they might have kiddos or they have nieces, nephews, grandchildren, neighbors that they might think would benefit from this kind of interceptive healthcare. I'd love to introduce you really quick, if that's okay. And then we're going to jump in.
Great.
So, all right, perfect. I have to put my readers on, Rafif.
hmm
Okay. Dr. Rafif Tayara, she's the founder of Junior Dental. She was voted Best Pediatric Dentist 2025. She's an international speaker, a book author, and a mom of three with 20 years of experience in the field of pediatric dentistry, sleep medicine, and early orthodontics. She's practiced in both private clinics and hospital-based settings in North America, the Middle East, and GCC countries. Her recently published book, Danny and Sarah Go to Dr. Smile, aims to prepare preschool-age children for their first dental visit. She offers functional and integrative oral health care and early corrective orthodontics with a focus on whole body health and well-being of babies and children. She is also highly skilled in treating and managing special needs children and has played a significant role in raising oral health awareness in the Middle East and the GCC region through various media channels and events. Um, your book, Danny and Sarah Go to Dr. Smile, it's your background. For those watching the YouTube version of this, how can people find your book? Yeah, it's so cute.
So the book is on Amazon, and then it's in bookstores. It's on Virgin Megastore. What is it? Kinokuniya. It's also in. It's actually sold also in Europe, on Amazon, UK and Netherlands, Belgium, and Germany.
Whoa.
So it's a little bit everywhere. I'm planning an e-version actually soon, for it to be more accessible. But I'm an old school girl. I love touching books. So I always wanted to just like publish like a book that you can touch. And I did it actually in we published it in Arabic and in English because one of the languages that I speak is also Arabic. My main mother tongue is more French. So yeah, but this book was really kind of inspired by my whole career as a pediatric dentist because what I noticed, after many years of practicing pediatric dentistry, that the main reason why kids are coming stressed or having this phobia or having this anxiety was actually transferred through their parent or their caregiver or
Yes.
something that they heard at home or something that happened or reaction or a feedback. And I wanted to kind of give them an independent storytelling of the experience, of a positive experience at the dentist, where they can read it and it will reduce the feeling of the unknown, and it will give them a more positive experience at the dentist, and will reduce this phobia. So this was really my attempt. And to be honest, since we published, I'm having a lot of kids who read the book and then book the appointment, and then they come and they're like, "Hey, I'm meeting Dr. Smile. Oh, that's your lamp. That's your Buzz Light camera. The X-ray. That's your surprise box." So it's
Oh,
been, I mean, beside the fact that it's been an amazing marketing tool, but I feel that it really gave children a positive look at how pediatric dentistry should look like, or how a first dental visit, should feel like. So that was, and I actually included my twins, Danny and Sarah. They're my twins, because they've been my as a single mom for 10 years before I was. They've been always my inspiration. I found strength in them that I didn't even know existed. So I feel that this book was like a true dedication to them.
I love
Yeah,
that. Man, aren't our kids our biggest teachers in life? They're our biggest teachers in life. That's how
true,
I feel.
true.
My gosh, I've learned so much through being a mother and inspired just from watching my own children. Um,
Yes, and you learn
so
things about yourself too, through
yes,
them.
yes,
Yeah. And
yeah.
I read a quote actually last year that says kids borrow um, a parent's mental health. And it's so important in dentistry, because you often see a parent, right, sitting, the child is on your chair and a parent is sitting, next to them or standing, and they're holding their hand, and you can feel how stressed they are. You can feel that they're so horrified by the dentist, but they're holding the hand of their child, and then, they tell him, Is she hurting you? Are you okay? Do you feel anything?" But just by saying that, they're transferring their
Yes.
own experiences, their own past, their own memories, their own negative, experiments or experiences at the dentist. And it's very important to be careful as a parent, what to lend to your child in terms of mental health, and what to keep for yourself. And this is a whole other podcast,
It
but
is. It's so funny. It's
but
a whole other
but
podcast
it's
because
important.
we used to send a letter, and it's making me want to do it again for pediatric patients ahead of time to the parents that your own personal anxieties and stress about the dentist is very apparent to your child. And it is literally being transferred to your child. And a lot of times, your well intentioned, your well meaning words of encouragement are the exact opposite, and they are doing more damage than good. So, the best thing is to let the doctor describe the procedure, let the doctor develop the relationship with your child, let the doctor earn the trust of your child, and you say as little as possible about the whole entire experience in the visit, because they'll say things like, "It's only going to hurt for a second," or "the needle this or the needle that." I'm like, we don't say those words around here.
Yeah, I say we
We
don't
don't
have
use
needles
those.
in the house.
We don't have needles
Exactly.
here. We don't use needles. And the parents like, "What?" And I'm like, yeah, we don't. So it's interesting. Um, you're coming to
It's
us.
amazing. It's amazing you do that. It's amazing you do that, by the way. It's amazing that you take the time to communicate with the parent, because this little gesture goes a long way.
It does, and they don't really realize it. And I've always, because I'm a dentist, I'm very aware of that. Like when my kids go to the pediatrician, I say very little. I I don't always go back, for certain things, because the first thing a child does is they look over at the parent like, should I be scared? And the parent just has a really hard time not looking nervous or not looking scared. So, and I'm a big believer too. I would never go back with my kid when they had a procedure like tonsils and adenoids removed or wisdom teeth removed or anything. So I'm like, I just don't think it's wise that a parent wants to watch anything any procedure on their kid. It's like, I don't think it's wise. Like, let the doctor do the procedure, earn the trust with the child, and then we'll bring little Johnny back out to you. I know we just went down this whole rabbit hole this but it's a good discussion. It's a needed discussion. Parents don't realize they think they're helping, but and I always tell the parent, like when the child is just not listening to me, I need them to be still. I need them to pay attention and let me earn their trust. So when I ask the parent to just step into the hallway, the child's behavior completely changes. And when the parent sees that their child completely changes when they leave the room, it's quite humbling, like, oh, I was part of the problem in this behavior situation. As soon as the parent
Yes.
leaves the room, we tell the parent, I'm telling you, it's so hard for a parent to understand, like, you aren't the only influential adult in that child's life that's going to help them. So we, as the healthcare provider, we are here to help your child, and we have tools and we know how to do it, and we have verbiage and language that calm them down, and we know they're going to be just fine. So if you let us do our job, we can help your child, and they sometimes just feel like they're the only person. And I'm very well aware I am not the only human in my child's life that can influence them, impact them, encourage them, and help them. And I learned that because I'm a healthcare provider. And so when parents step out of the room and they see this whole different child emerge, it's a little bit humbling sometimes. Like, oh, I mean, I was the problem in the room. I thought I was helping. So you're in Dubai, and
I'm in Dubai.
okay, I don't know the culture with early interceptive ortho from what the culture is like there in healthcare and orthodontics and in pediatric dentistry and dentistry as a whole. But from what we discussed before the podcast, it sounds like it's very similar to the United States. So, some of the things I'd love for you to share your journey as a pediatric dentist and how you went from, the traditional pediatric dentist everyday paradigm to what you're doing now and how you got
Hmm.
there.
Yeah. So I moved to this region, I think in 2008, straight from Montreal. And this region in 2008 was very, was back then the healthcare market or the healthcare ecosystem. It was it was much more immature than now. And I was a pediatric dentist working at an American clinic in Abu Dhabi, actually. And that clinic was owned by a guy, a dentist from Kentucky, who
What?
came who ca- who came here like 40 years ago and founded this American clinic. So we were all American dentists, Canadian dentists, European dentists under one roof doing like a multidisciplinary treatments for our patients, our kids, the adults. And that was when my journey started. And then I changed few practices. I moved a little bit. I worked in Qatar also for a few years. I worked in Dubai. I worked in Abu Dhabi. And then at the end last year, I opened my own clinic. But the healthcare ecosystem for healthcare professionals here or for dentists is very like there's a lot of varieties. I don't think it's as like mono-colored like the US. So you have a little bit of everything. You have dentists from all kind of nationalities and backgrounds and cultures, doing their professions. So there's a lot of differences, right? Because the school education schools are different and the school of thoughts are different. But I started my career as a pure pediatric dentist, and in our education system, pediatric dentists are typically treating and managing early childhood cavities. And this is the basic early childhood cavities that you see every day, and depending on the region where you are, you have to deal with it, the incidence and the prevention and the breastfeeding and the on demand and the milk, the bottle of milk, right? All those terms that you're familiar with. But then we know that early childhood cavities, it's three things, right? The host, the tooth, the bacteria, and the saliva. But then I noticed after a few years of starting my career as a pediatric dentist, and here 80% of children in this region have cavities. So I deal with high risk kids every single day of my life. I noticed that I'm getting so much relapse of cavities. And then the third factor, which is saliva, when it's down because of mouth breathing, I'm getting too many cavities. The
Yeah.
cavities are coming back. No matter how amazing I am as a pediatric dentist, no matter how much the mother has a high dental IQ, she's brushing well, she's limiting snacks, everything. But the factor of zero saliva at night is actually making my treatments fail, and I was getting nowhere. So that was really, I think, where my journey started back in the days. That was like 15 years ago. And I started looking, I'm like, okay, this is not going anywhere. I need to look far beyond the teeth and the host and the bacteria and the saliva. And that's where my journey with airway and sleep medicine and function and tongue and palate and adenoids and the retruded mandible, everything started there. And that's why I started digging and digging and digging. And like, I mean, just like your journey, I believe for everyone who went into that field or who had the curiosity of learning beyond teeth, you feel that you need to learn so much pieces of the puzzle in order to understand the full knowledge. And even until now, I feel I'm still learning and I'm still seeking, more education. I recently did a residency in sleep medicine at Tufts. So, and even with that, I feel that it's not enough because they talk in sleep medicine a lot about adults, but there's not enough talking going on for children, right? We do great mandibular advancement protocols and intraoral appliances for adults, but when it comes to children, we still don't have very clear guidelines. The
Correct.
sleep tests are not clear. There's a lot of unclarity there because we don't have enough review of literature, enough studies, enough protocols that are strongly built. And I think this is where, it made me so passionate to dig more and to understand more what's happening in the mouth of the child. And as pediatric dentists, we have this huge privilege. We're so lucky that we have the opportunity to detect those red flags very early in the life of the child that GP dentists or orthodontists do not have that chance. So it made me really realize a lot of things, and then I started looking at different things. And they say if you don't know what you're looking for, you will never find it, right?
Right.
if you
Right.
don't know how if you don't know how a tongue should be positioned or how a child should swallow, you will never realize what the child is doing wrong or right. You have to know what you're looking for. So
Right.
that's where my journey started.
Well, it's so true. If you don't understand the tongue and function, I mean, and really in dentistry, if you're a general practice or primary care dentist or pediatric dentist or orthodontist, and your only focus is, I always say, the white things, just teeth, and you're not looking at that whole oral structure, and which includes it's housing a very strong muscle we call the tongue, which
Yes.
guides growth and development. And you are building a home for that tongue to live. You really have to understand, where should the tongue even be? How is that tongue even functioning? Your tongue can be the best orthodontist or the worst orthodontist. That tongue can push those teeth out of the way. It can keep them right where they belong. The function of the muscles can keep the teeth where they belong. So yeah, if you don't know those things, there's nothing to see here. Just move on and do what you were taught in school. Um,
Exactly. And
yeah,
and about what we were taught at schools, the dental education systems also are still all focused on teeth. So we were never trained, and I don't know about you, but I feel like in my education system, we were never trained to look beyond teeth. We were never trained to have the mouth or the palate or the teeth as part of the airway system of a child. And this is something that you feel now. I feel that in the last year, I kind of flipped that mindset. I'm seeing things from a different angle, from a different perspective, in order to serve my pediatric patients better.
100%. Um, so you and I were talking before about resistance. And you are on social media, and for people wanting to check her out, it's in Instagram. It's at Dr. spelled out Dr. Tayara, Tayara. And then she also has at juniordental.ae. And she's on LinkedIn too, but I'll get all that stuff and put it in the notes. But you said, I'm just getting so much hate, and I said, which is so unfortunate. You and I were talking, people can disagree and be respectful. But we also both are very confident that in 5 years, we know we're going to be the ones that were correct because we see it. And so we can't unsee it. And there is plenty of research out there, and there is, it's just more medical journals. And you have ENTs, you have sleep physicians, and coming to us going, hey, can you help? This kid cannot tolerate CPAP, which a lot of children can't. Heck, a lot of adults can't. And there are orthopedic protocols, especially if you know where the collapse is in the child through DICE, which is drug-induced sleep endoscopy. You can kind of see where that collapse is, and there's certain orthodontic protocols that, could potentially help the child, whether it's some transverse to provide more tongue space, more sagittal to help bring the maxilla and mandible more forward and create more oral pharyngeal space, get the soft palate less collapsible that way. And we can see CPAP pressures come down. We can see children come off CPAP. So it's really, I want to say insane almost for people to say it doesn't help.
Yes.
It's almost
Yes.
an
And moms
insane
moms see
statement.
the difference.
Yeah,
That's the
it's
thing. Parents see the difference. They see it, and then they see their child. I have children that where, their moms, they see them transform, they see them thrive.
yeah,
They tell me this is a child that I don't even recognize, after a treatment. And most often, we as pediatric dentists are even detecting ENT dysfunctions, right? We're detecting fluid in the ears. We're detecting obstructions that parents did not know that they existed. A lot of parents still think that snoring is normal, that it's cute.
yeah,
So those are all things that we deal with on a daily basis, and when we help them, and we're not saying that it's like one thing that works alone, but it's the combination of treating the function, um, um, you know, uh, checking the airway, managing the breathing, expanding the jaws to be able to have more volume, for the breathing and to reduce the resistance. And all those things together, they need a multidisciplinary team. They need people working together to make the quality of life for a child better. And it's not just one thing.
correct. And that is what the medical literature is showing as well. It is a combination of collaboration between the ENT, so addressing the enlarged lymphoid tissues. It could be adenoids, tonsils, lingual tonsils, which, there's a lot of potential systemic issues, inflammation, gut health, that
Allergies.
allergies. We haven't even, we're still learning about all this, but you need your
It's true.
ENT. And for right now, this is it. We got to get a child breathing. They're big, they're not shrinking. help the child not suffocate.
Exactly. Yeah.
And then now you've got all the craniofacial, dental facial, orthopedic problems that have resulted from poor breathing, from poor function. So we have to address that. And then you have to address the function. So there's a lot of different components to turn on and work on together. It's not just one piece of the puzzle or not one thing, but we are a piece of the puzzle. And I'd like to remind people, like my background is adult dental sleep medicine as a primary care dentist. I've been doing that for over 20 years. And it's very basic logic. Okay. What we are doing with adult sleep related breathing disorders right now is very anatomical based. Are there non anatomical aspects to a collapsing airway? Absolutely. There are influences from, we see vitamin D levels and different things influencing airway. Sasha Gamenak has a lot of interesting research with, micronutrient deficiencies and how it impacts all sleep disorders, including some we might identify as anatomical too. But what we are doing with adult sleep, we're either advancing a mandible and the base of the tongue, which also advances a little bit. It decreases pressure on the soft palate. When you bring the tongue base forward, you bring the mandible forward, you're also moving that soft palate a little more forward too, because the tongue pushes against soft palate. When you are doing CPAP, you are taking room air and you are blowing it forcefully. It's like a reverse vacuum cleaner past a soft palate to open that oral pharyngeal space. When you're doing maxillomandibular advancement, you are taking a maxilla and you are taking a mandible and you are moving it more forward. What is it doing? It's moving tongue base and it is moving soft palate. These are anatomical influences that help adults manage their airway. To say that those very things do not help a child is ridiculous. So, how do we move a mandible forward in a child? Well, we're going to look at orthodontic intervention to move a mandible forward, to move a maxilla forward. It is not unreasonable that orthodontics influences airway. It's just not. It's an anatomical
Yeah.
thing. To make a statement that orthodontics doesn't influence airway, I would be embarrassed to say something like that. But I think a lot of them are coming from, well, this is what I was taught in school, and we don't have any literature in orthodontics. Well, you know what? You don't understand sleep medicine either. And maybe you need to expand your education and look at sleep medicine, which is something you've done, Rafif, right? So you look at interceptive orthodontics, you look at sleep medicine, you're looking at the child as a whole. You're not just looking at the teeth sitting in the bone, you're looking at the bone.
True. And we're looking at the child, at a very, very early age and understanding how he got there, right? Because you see a 30-year-old or 20-year-old or 40-year-old, mouth breathing, snoring, ADHD, can't focus on an email, it's like can't sit still on a meeting, on a video call, all those things, right? And
Right.
then you remember that adult was one day a child, who came to a dentist, but there were things that were dismissed or ignored or not seen. Where was his palate? How did his palate look at that moment? How did he sleep at that, did he bedwet? All those things. So those things are very important, and we do this every day. So we combine myofunctional appliances. We sometimes have to do maxillary expansion. We build our own protocols into doing that. And I'm a top provider of Invisalign First and Invisalign palatal expanders too, at the practice. So we do a lot of those And then we make room, just like you said, we make room for that muscle that needs to work, and sometimes is just dormant because of all
Yes.
that. It's not functioning. The habits, also the pacifier, the thumb sucking, all those factors. So looking at everything together, and stopping the factors that are contributing to that, and re-educating the patient's function, muscles, child. And often I work with pediatric osteopath. I work with myofunctional therapists, that does the whole sessions and exercises and homework with the child, because as you said, it's just not us. We need more hands to clap, and we need less to be attacked, because the old school orthodontic system is still trained just to look at teeth, and we need to be able to look at the child together and combine our knowledge to be able to serve them better, and become more a patient-centered system, rather than just serving the doctor or the system, or who refers what or what refers who. So this is important.
It is important. And, I hate that you get hate. I mean, I really do. I, it just is so frustrating to me. I mean, it would be just as disrespectful if I were to go on their sites and just attack them for what I think is their ignorance, right? And it's like we would never do that. Like, why? It's not necessary. And I think a lot of it, I was saying to Dr. Jackie Demko, I did a podcast with her yesterday. She's an orthodontist, and she said, really, we were talking. This is fear. People attack out of fear. So when they're saying, who do you think you are? It's because they're concerned, really. They might be missing something. They're not even quite sure what they're missing, but they don't even want to evaluate what they're missing because their life is comfortable. And how dare you challenge my current state of how I run my practice? If you challenge that there might be something I'm missing, it means I might not be helping people the way I think I'm helping people. I think I'm doing a fantastic job, and you are challenging my current paradigm. And there's fear in that. There's fear of them looking back at all the things they've missed potentially.
Mhm.
And there's fear of changing the practice. And we say this almost every podcast, that a lot of the attacks happening are fear-based. It's like, just, keep your head down. If you don't think I'm helping people, what's it to you? You just keep doing you and leave me alone, because I know I'm helping people. But no, they feel like they have to say something. And, or, why are you expanding a 4-year-old? I say too, it's interesting. There was a paper written over 100 years ago showing primary dentition with spacing between baby teeth, and no
Mhm.
and no spacing between baby teeth. That is a malocclusion. When you do not have spacing, it'd be ideal to take like a nickel and put it in between every baby tooth, because
Yes.
the bone that shows you have enough bone to provide a home for permanent teeth that come in that are much bigger than baby teeth. When you see that, that is a malocclusion, and you need to immediately go, what's causing this?
Yes. But ironically, it's not in the dictionary of an orthodontist to expand a primary dentition with no spaces between baby teeth. And that's the whole, that's sometimes it's, you're attacked to do that.
Well,
Like,
what
how
they're
come you're
waiting
expanding?
for, they're
Yeah,
waiting for
exactly.
the
And
big
I
teeth to
I
come in and
started
be jumbled.
I started doing that, I think 7 or 8 years ago, expanding on primary dentition. And I don't think, looking back, I don't think I even found a lot or many backing him up. I was even so attacked that I was doing that, I was putting an expander on a primary dentition alone. And I remember it was really like, I almost we had really a lot of conflict in that practice at that moment. And I found one Italian orthodontist actually in Italy who had so much research about that, who actually did it and even gave webinar about that. And that's how my journey started with the expansion on the primary dentition level. And it was such an eye opening for me. It was like as if like a door opened to me, and I started learning. And now it's more of a norm. Now you see more and more people is even in guidelines, expanding on prime. Even now, orthodontists are doing clear aligners on primary dentition. So
Yes,
it's
yes,
but those things were unheard of. Even they were even like how do you say, frowned upon. Like how, like what are you doing? It's almost like unorthodox to even do that. But now they're being more and more the norm. That if you see, and even in the new guidelines of the AAPD, this is now more of an encouragement to actually detect red flags for airway, and then you need to intercept because you are, correcting and guiding and the growth and the development of a child.
yes. And, we wouldn't look at a kiddo who, I mean, and you have to, that's the other thing. When you see those, no spacing, it's like ask questions, start, because you have to ask, why is it like this? And then you might find out a lot more about that kid if you start asking questions like, how's their sleep, mom? Do they toss and turn a lot? Is there any bedwetting? Do they have any ear infections? Have they have tubes put in their ears repeatedly? Are their
Yes.
lips
Are they
dry?
picky eaters?
Are they picky eaters? Are their lips dry? Have a high cavity rate? I mean, there's a lot of different things we can be looking at when we see no spacing between baby teeth. It should be an alert. This growth and development is not where it should be. It's already behind. They're already deficient in the bone that they need to house the teeth they were given. So asking questions and seeing that as a malocclusion as it is. I mean, that was in an orthodontic journal 100 years ago. And Europe, some European countries have been doing this expansion and seeing benefits for decades. So it kind of just depends on the pockets where you're at. And yes, now you are starting to see Invisalign First. And if you get in
Yes.
earlier, we actually can help, not even just from a systemic whole body wellness, which is what you and I are pushing for, but even orthodontists that I know that have been kind of slower to this journey are seeing amazing things when they get in earlier. They're finding
Yes.
that if you get in earlier, I'm actually creating room where normally I would have had to do bicuspid extractions.
Exactly.
That child's more
Yes.
malleable. I'm able to guide the teeth in. The bone is growing. It's like, oh, wow, I don't have to take teeth out
Yes.
unnecessarily. So even just from um, an aesthetic perspective, because you know what? All your teeth in is way more attractive than taking out bicuspids. I mean, it just is.
And
And
healthier, right?
and
Because
healthier.
when you remove teeth, you remove airway space. You remove volume for the tongue to sit. And I see that also as a pediatrician. I see the parent, right, who comes, and then the child on the chair. And then when I examine the child and I get all those questions that you started talking about, there's also the genetic component. So now yesterday I had a dad telling me, well, I'm on a CPAP now, and I'm not even wearing it. And, my wife kicks me out of the room. We sleep in different bedrooms, all those things, right? And now I'm seeing all those little red flags in his daughter. And he's telling me, I don't want her to be me
Yes.
in 30 years, right? So when we have the ability, when we see that in front of our eyes, I mean, those things you cannot erase, you cannot hide. You see it happening, you need to do something. And the reality is now is most of our early interceptive orthodontic work, myofunctional, all those pieces of the puzzle that we talked about, when you do them right at the right time, you either erase a phase two, there's no more phase two, or the phase two is very minimal. It's so
Yes.
simple. So the orthodontic treatment later is not complex anymore. You don't need much.
Well, and I think that's another paradigm shift, right? So, Dr. Mariana Evans, she teaches in the United States with early interceptive expansion orthodontics. She is, I learned a lot from her early in this journey. Actually, flew my son, who now
Mhm.
has graduated college, but I flew him to her in Pennsylvania to have expansion because no one in my town would do it, and everybody was just trying to cram his teeth in, and he was 14 and he had the maxilla of a 5-year-old basically, and everybody either wanted to take his bis out or just flare his teeth, and it just was horrible. So we created a lot of beautiful bone for him. He has one of the most broadest, beautiful, people comment on his smile all the time, but she has said this repeatedly. The heavy lifting of orthodontics is the orthopedics that we are doing up front.
Yes.
And the well-being, the whole body, the systemic changes, the life changing is the dental facial orthopedics that we're doing up front. But how the current pricing is in most orthodontic practices is the heavier fees are on the phase two. So what happens if you don't need phase two? Now you've got a big shift in orthodontics. What if they only need 6 months of a little bit of alignment because you've now created bone and the teeth know where to go, and you might want to tweak some teeth. So it does. It's a challenge to the current paradigm because really orthodontic schools here in the United States are heavy, heavy 12 years and older because they're kind of just waiting for them to get all their teeth in to teach these ortho residents how to do braces, how to straighten teeth. And I love our ortho schools. I mean, they learn so much about growth development. But the reality is they're not doing much dental facial orthopedics. Most orthodontists graduate in the United States not with a big understanding of a lot of phase one and the power of phase one. So most of them are in schools where parents are bringing their kids for more affordable braces. That's just what it is.
Yeah.
And they don't do any expansion unless they see a bilateral or a posterior crossbite with teeth. They're not necessarily looking at skeletal crossbites, so that's a whole other topic there. But I just was so impressed with everything you're doing, and I just feel for you because I know what you're going through, and you're not alone. And I'm so proud of you and everything that you're doing in your clinic. And you've worked very hard to do what you're doing. And you're like, you know what? I just keep my head down. I move forward. I know I'm helping patients. Parents are telling me that their children are changing. I mean, there's so much failure to thrive, these
Yes.
kids. And you just see a whole new kid bloom. And when they sleep better, and I love what Audrey Yoon is doing. She is it's the first, I believe, ortho residency at Pacific. Orthodontic residency has they now have mandatory sleep medicine training. And
Yes, that's amazing.
I think,
I love Dr. Yoon.
oh, what she's doing, what's great about her too is she is now creating
And she is a dual trained, she's a
yes,
pediatric dentist and orthodontist. And that's the beauty of it because don't forget that a lot of the reluctance of orthodontists also historically treating kids is also the fact that they cannot access them from a behavior management perspective. And when you cannot even scan, right? When you cannot take the impression for a child, right? To actually do the rest of your work, even if you want to, there's no way you're gonna be able to do it. So So I would, we would love to have even orthodontics residencies with, incorporating more of the behavior management more, because you need to access, right? You need to gain the trust of a child to be able to do the work at a very early age. And orthodontists in general, traditionally they're not really trained to see kids, and that's why when you see them in private practices, orthodontists, they just like, you know what, come back next year. They put them on this monitoring
Come back
method,
in 6
mode in their
months.
files, and
Hmm.
exactly, come back in 6 months, come back when I see that molar, come back when you lose that incisor. But then
Come
the more
back
you
when you
wait,
can
the
sit
more
still.
exactly, exactly. Come back when you're more of a grown up, and then you can, accept having your mouth open without me saying anything. So that's also the ugly truth, right?
You nailed
But
it,
it's
Rafif. You nailed it. Behavior management. Kevin Boyd says this all the time. There are a lot of problems that are keeping, the orthodontic community from fully coming on board. It's a definite paradigm shift in training orthodontists. They don't understand sleep medicine, and they really should understand dental sleep medicine. And the American Dental Association believes that there's such an overlap, that we all should be screening and asking these sleep and breathing questions of our adult and pediatric patients. So this needs to be
yes.
in the orthodontic community,
And there's also
training.
the time issue. I was watching a webinar also in, I think, in California like 3 weeks ago. I was so curious. I woke up at like 4 a.m. in Dubai because the webinar was like there at 6 or 7 p.m. With tooth fellow, and I don't want to
Oh
promote
yes, yeah,
tooth fellow,
I
but
know Ben
it was it was
Moralia. We've
so
had.
it was it was so interesting because some dentists were saying, well, I don't have time. I don't have time in my practice. As a pediatric dentist in the US, you see 60 kids a day. They don't have time to ask the proper questions. They don't it's an income-based clinic on prevention, right? And on nitrous oxide. I don't have time to ask my parents, is he eating well? Is he chewing the right food? Is he lacking vitamin D? Is he getting enough red meat? So that's also another problem, right?
Yeah.
Finding ways to maybe have the questionnaire in the waiting room. Finding also, it's also a practice management level, right? Finding
Yeah.
ways to try to be able to get those answers in an efficient and a costly way where it doesn't also cost you your whole day of income. So there's so many aspects, but we'll get there.
We'll get there. And you know what? It's an awareness. We have to identify what the obstacles are first to even address them and try to shift the paradigm, behavior management, the practice management model, and understanding of the overlap of sleep and breathing health and how that does overlap with dentistry, period. I mean, there are several little points for us to hit on, and I feel like we just got started, so I probably feel like we need a second podcast, you and I together.
Yeah.
But I appreciate you being on today, and stay curious, keep learning. We all are learning, Rafif. Every day there's something I learn too, and I'm just thankful that you are brave and so compassionate, and your patients, your community is so lucky to have you. And I'm so blessed that you came on today, even though you went to a Tiesto concert last night and you were screaming your head off.
And I almost lost my voice and my ears.
Your voice and ears, like, I'm glad you can hear me today and you can speak after Tiesto last night. Before I let you
But
go,
Tiesto is worth it.
oh, I love Tiesto. Love it.
And
Oh
my
my gosh.
and my husband is Dutch, so that was like that was an
Oh,
extra, that had an extra flavor.
that is awesome. I love it. Um, Before we go, I had three questions to ask you that have nothing to do with any of this, just so we get to know you a little better. But what is your favorite way to start your day? Number one.
Oh, a cup of coffee and silence.
Ooh, nice. Especially with
But I think
kids.
that's for every mom. Yeah,
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 especially
exactly.
with kids. That silence sounds beautiful. Um, okay. what is the craziest thing you've ever eaten or you would consider eating or you're consider eating?
Oh, that's an easy one. I was in Thailand, I think, many years ago, and I had those fried cockroaches.
Oh gosh.
You see them, you go to the market, you walk, and then it's like is
Are
you're
they
overwhelmed
everywhere?
by all those flavors. Yes, they're everywhere in Bangkok. Yeah. It actually didn't taste that bad. It's like crispy. It's like chips. It's like salty chips. That's how it
Really?
tastes.
So there's no
Sorry.
gooey center?
No, no, it was just yeah, it's a certain type, It's not like the regular one maybe in the US.
So it's a
Yeah, it has
special
long nuts.
kind of
I don't want to
cockroach.
describe it. It's
Oh
gonna yeah.
God. Oh my
But
God.
that was the craziest thing. I would have never thought that I would be brave enough to eat that. But I'm like, you know what? I'm here. I'm just gonna, you know,
You're
I'm
going
gonna
with
just
it.
explore this guy. Exactly. I'm going all the way through and then I'm gonna do it. So it was done. Yeah,
I
I was
love
like,
it.
check.
That's so funny. Okay, last thing, and this might be a little harder. What is something about you that you would want people to know?
Oh, um, I think I'm a little bit like crowdophobic. So when I don't do well with crowds, yeah, I want my own space. Not everyone knows that about me. I try to hide it, I think, because I'm every day I'm with people, with patients, with parents. Yeah.
And so you decided to
But
go to
I like
Tiesto, a
quiet. I
Tiesto
like
concert last night.
It was special. No, no, that was special. It wasn't your typical concert that you would go to in an arena or something. It was actually on the
Really?
beach. It was super. Yeah, yeah, yeah. It was a concert on a beach resort, so it's very private. Yeah, yeah. So you had
Oh,
tables and everything. So you don't touch anyone. You're not like yeah, yeah. You don't have like shoulders rubbing on each other or anything. So it was very nice. We had our
this
own
was on a
table and
beach?
overlooking the water. Yes.
That
Yes, it
sounds
was very nice.
fantastic.
Super dreamy. Super dreamy. I'll send you the photos. It was
I
very,
would
very
love
nice.
that. Please do. It sounds amazing. Well,
Yeah.
um, thank you. I am so happy to have gotten to know you better, and the listener got to know you better as well. And we'll put ways for people to reach out to you, learn more from you, and become, a patient of yours potentially, or just even, maybe ask questions of you. You're a wealth of knowledge, and I just appreciate you taking the time, Rafif. I really do. You're an
Thank you
amazing
so much
person.
for having me. Thank you so
Absolutely.
much for having me, Stacy. It was such a pleasure.
Oh, thank you. And
And
thank you,
hopefully we
listener.
meet in the US. Hopefully
Heck
we meet.
yes, we got to figure that
Yeah. Or
out.
you
Well,
come to Dubai.
hey,
We have to
that
we
is
have to
on
get
my
you to
list. I'm
Dubai.
not kidding. I would love to go to
Yes.
Dubai. Would love to. Thank you,
Get some
everybody.
sun.
And yes, we'll catch everybody next time. I'll see you later. This podcast would not be possible without the inspiration of my dad, Daniel Becker, and creative direction and editing from the very talented Jason and Dane Becker, Ben, Lydia, and Judah Walker. To stay connected and keep the conversation going, be sure to subscribe to our podcast and visit our website at asappathway.com. And please remember, the information in this podcast is for educational purposes only. It's not intended to be used as medical advice or to replace your healthcare provider's diagnosis or recommendations.